Thank you very much, everyone, for coming in for a chat about what we've called the golden triangle of clinical AI. Probably could have come up with a better name, but this is what we're sticking to, and it's on the slide now. So, and Eolas and what we do, but then we'll really dive in, trying to keep it actually a bit more conversational about where we think the future of clinical AI is starting to travel, and what that means for health systems and how we should be thinking of building that out. The clicker isn't working, so I'll be walking back and forth to do the button. So very quickly, a bit about myself. So I'm a medical doctor by background, worked in emergency medicine for about 5 years, and I'm also a software engineer as well, and I built a system called Eolas to help our hospital manage all of their own institutional knowledge and information. So when we were treating patients, it was very difficult for us to get that information. So someone's having a major heart attack, someone's got a severe infection, what exactly do we do next in our health system? So specifically, it's about the institutional knowledge, not about the external knowledge, because the tools exist there. You know, you have UpToDate, you have open evidence, you have lots of other external tools. This is for health systems and how they can streamline their knowledge to the point of care. So we built that system. It uses AI, it indexes all of that knowledge, and then the doctor, nurse, pharmacist, any healthcare professional just asks a question and then gets the answer to their question. We launched it about 4 or 5 years ago. It's used in about 600 sites across the world. So about 90% of all hospitals in the UK use it, and then there's about 40,000 users in the US across places like Stanford, Mass General, Boston Children's, a number of others. So that's a very quick background about Eolas and kind of where we fit into this in general. But ultimately, we're here to talk about where that fits into clinical AI in general and where the direction that we're traveling in. And I think the core is to start with is what is the core of healthcare, and it's that healthcare professional patient interaction or health system patient interaction as health systems become more autonomous. And ultimately that's at the absolute core of this. And what needs to happen for everything downstream of that, for treatment to happen, for pathways, diagnosis, etc., there really needs to be 3 things. First of all, we need to listen to what the patient's telling us, and that interaction is key. So the history of the examination and capture all of that information. We also need to be able to either before that or after that know what has happened with that patient to date to this point. You know, what's their history, how many times have they came here before, all their labs, all their scans, everything about that patient to date. Then what we do is we just take all that information, assimilate it, and then query a knowledge base to decide what to do next. Historically, over the last 1,000 years, that knowledge base has been in the clinician's head. They go to medical school or pharmacy school or nursing school, learn loads of stuff, learn things throughout their career, and then take that first 2 aspects and then query a knowledge base and decide what's the next best treatment. So that is now what is really rapidly evolving. And those 3 points are actually converging, and that converges to the point of a kind of decision being made. And this is the framework which we kind of analyze what is going to happen with AI down the future. So you have the conversation synthesis, what's being said in the room or the telehealth visit. You have what's known about this patient, which usually lives in the EHR. And then you have the query in the knowledge base. And this is now all coming to converge at one single point of the moment of clinical decision. And you know, where we think this is going, if we zoom forward in 50 years' time, this will be autonomous. That's what's going to happen. AI is ready recording what's been said in the room. It's ready taking all that knowledge and taking all of that information. We already know all of the history about that patient. Yes, it's very unstructured. Yes, it's very difficult to deal with. But ultimately, the EHRs are now starting to do a better job of summarizing all of that information. Now we're able to take that and then query a knowledge base, both external, what's the latest world's medical knowledge, and internal, i.e. this system, this is how we want you to work in the system, this is how it's done. And then you're able to start taking actions downstream of that. So that will form an instruction set, initially for the clinician. Eventually that will form an instruction set for an agentic AI. And that's really the direction this is traveling in. So how far away are we is the question, and that's really what kind of we're going to dive into here, the stages of maturity here. We're at different stages of maturity, and I split it into those 3 stages, and then the knowledge is split into external and internal. So conversation synthesis, we're actually quite advanced there. We're getting to the stage where most systems are either thinking about using one, actively using one, or all the clinicians are using one themselves without really telling anybody. So we're quite advanced there. Chart synthesis, the EHRs are doing an okay job at summarizing that. There's a lot of startups and scale-ups in the space now that are starting to summarize that, so we're not as advanced as the conversation synthesis, but we're getting there. External knowledge, again, we're at the very late stage. Internal knowledge, this is the bit that's messy and very, very difficult, and most systems are very early in this. Most systems either aren't thinking about this, using SharePoint, or the information lives in people's heads. And that's at the earliest stage. So taking each of those in turn and seeing and trying to examine them a bit deeper before we're able to know how they converge. So conversation synthesis, so in other words, ambient listeners. So basically they're fairly ubiquitous now at this point. VC money has poured in and there's been hundreds and hundreds of millions and lots of companies, and ultimately it's all converging down to probably 5 to 10 new winners in one bucket, and then electronic records in the other bucket. So most systems are either going to do one of those things. So let's use what's in Epic, or let's use Dex from Microsoft, and there's about 600 plus organizations currently doing that. Or they fall into the other bucket, which is let's use a startup, scale-up company, so a Bridge, Ambience, lots of others. And about 200 plus systems are using one of those, so that falls into one of those two buckets. The good thing is that it's working. Evidence is a lagging indicator, which is an important note to make here as well. Everyone kind of feels that it's working, but the evidence is now starting to slowly show that it's working. Evidence will show more and more and more and more the benefits of it. So one of the big pieces that has been really shown is that it reduces burnout rates amongst clinicians, so it reduces pajama time, better documentation, etc., etc. It increases efficiencies, and there's lots of evidence coming out to show that as well. Will it improve patient care? I think it probably will, and I think we'll probably see that coming out in the evidence over the next kind of 5 to 10 years. It's a difficult question to ask, and it's a difficult question to empirically study, but I think the evidence will show that. So we're fairly mature in that. Any comments on that? Any questions in and around that? Because I know people are thinking about this and procuring these systems. Any thoughts? No? Good. So that's really the ambient listening bit of this. The chart synthesis then, this is in summary EHRs. There's maybe 10, 20 startups doing this that have some sort of traction, but ultimately they're living in what we call the EHR kill zone, so it'll eventually just be enveloped back into the EHR again. So Epic has their own summarizing feature, Cerner has their feature as well, and every other smaller EHR is now starting to build that. In other words, what has happened with this patient up to this point, and what's the summary of that? That's what this point of the triangle is. Then we have external knowledge synthesis. So elephant in the room is open evidence. $12 billion company, raised 700 million. 50% of US physicians use this on a monthly basis. And there's about 80% of them using it in total. Either open evidence, up-to-date AI, or Doximity's AI. So generally that's kind of where this is now sitting. And again, very, very important part of this triangle. This world's knowledge doubles, world's medical knowledge doubles every 73 days. That's like the figure that's always kind of batted about. In the 1950s, if you graduated medical school, within 50 years, what you knew would be out of date. Now, every 73 days, what a clinician knows is out of date. So in other words, it's impossible to keep up with the latest medical literature. So this is a perfect use case for AI to be able to streamline this and put it to the point of care. And this has now been integrated at the point of care as well, and it's taking patient contact. So most physicians are using this where they take their phone out, ask the question, get the answer, or they type, get the answer, and that's it. What now systems are doing, so Cedars-Sinai, for example, have an integrated system where they pull from open evidence, query the patient record, and both of those then help that physician make the decision. Now more and more systems are going to be doing that. But they're still pulling on external data, and that's great, it's needed, but if it recommends here's the best next treatment that can possibly exist in the world, but this health system doesn't offer that, then that recommendation is completely useless to that physician. So what we need to supplement, and we're trying to build a company in this space, so that's my declaration of interest, but what we need to supplement that with is internal knowledge synthesis as well. And this is the messiest problem, because generally how we think about this is two buckets. It either lives in people's heads, so it doesn't exist on paper or digitally, and we call that tacit knowledge. So how do I organize an MRI scan on Friday evening when everyone's away home? Things like that. Or it's officially written in a policy and procedure, and then that's put in SharePoint and no one ever looks at it again unless there's a legal case. So generally it lives in those two locations. So it's messy, it's hard to get access to. It's also very hard to govern. Who owns this, who stands by it, how do you make that process more streamlined? So all of that, AI is perfect for that. It helps streamline all of those processes. It helps query the latest evidence to see if your guidelines are up to date and coherent. It helps you solve all of those problems. The other problem then is adoption. So over the last 50 years, there's been lots of clinical decision support systems that no one has used. And clinician adoption, specifically physician adoption at the point of care, is very, very difficult. It has to be accessible within seconds, or it has to be just right there in the EHR. It has to be within the context. And that's, again, perfect use for AI. The most important point about this is the most defensible bit of the triangle. This is very specific to your health system. You can't turn to ChatGPT and ask, in my health system, what do I do? You can't turn to Open Evidence and ask that until they are able to capture all that information. So it's very, very defensible, and it's very important that your health system starts to build this kind of muscle. And I kind of covered this. So what does it take to make this real? What does it take to make it happen? So first of all, you have to be able to ingest the content. So all of the policy, procedures, guidelines, take them in any format. AI can take any different type of document format, break it down, chunk it, and then store it for querying purposes. Or you have to be able to crowdsource that information, that knowledge from clinicians on the ground floor. I've been able to ask them questions, what do we do? And again, AI is perfectly placed to do that. It has to be then governed, and then it has to be delivered at the point of care. And one point about this that is kind of, Open Evidence has perfectly highlighted this in the fact that I think there's a lot of conversations around integration, and that's really important. If you go to any CMIO, they'll say this needs to integrate, 100% it does. And the problem with that is then it leads you down the path of IT, and IT say we have to have MFA, so obviously cybersecurity is extremely important, and we heard that from the talk, but they go down the path of we need MFA, we need multiple logins, we need to jump through 6 different hoops, and then you need to log your birthday and tell me the name of your first pet. And doing all of that stuff, when you have a patient in the emergency room who's actively having a heart attack, you're not going to go to look at that because it's useless. So yes, it's brilliant that all of the information is there, but no one can access it. So it has to seamlessly be accessed, and this is why 80% of physicians are using Open Evidence, because they download the app on their phone, they sign in once, they take it out, they ask a question, and they get an answer. And this is why it's taken off, and this is why it's got such ground adoption. So the ultimate question is, how do we get that balance between being safe and secure, but also being able to make sure that that information is easily and seamlessly accessible? What we think the solution here is having one single brain, so one single brain where all that information lives, the ability to take that brain, integrate it where it needs to be integrated, but also for that information to be seamlessly accessible by devices that are not there and not connected. In other words, in the emergency department, you can just take your phone out and in resus, ask a question, get an answer, and then put your phone away and treat the patient. Because clinicians make decisions generally at 3 points. They will lift a chart before they see the patient and say, okay, someone's having severe chest pain, I think I might want to look up the STEMI pathway before I see this patient, and then look it up before they see them. During the consultation, they'll get decision support brought up in their EHR, and then after the consultation, they will want to query information to make sure that what they're doing is right. So at 3 different points in times, in 3 different workflows, they need to access that information. It's important that that all comes from the same brain. And that's really the key to making sure that this is governed properly, but also seamlessly accessible. Lastly, and most importantly, it needs to integrate with the triangle. So I'll go back into the slide here just to show the triangle. This needs to integrate, because if we don't sync all of these together and we don't build the system in this direction, then these will all be standalone systems, and it will just be bloat, and there will be no way to actually move towards this idea of an autonomous health system. And what we're seeing now is everyone's starting to converge and move in this direction. So a bridge will no longer describe themselves as an ambient listener. They'll describe themselves as an AI care partner or something like that, because they have integrated with knowledge bases and they're starting to do pre-charting and things like that. Epic are starting to say that we're able to do this decision support. They're starting to offer more modules that do that, and they have then moved into the other corner where they're offering the ambient listening technology as well. So these are all starting to converge in one place. Ultimately, what health systems need to do is plan this deliberately, because we had seen this happen before. A few decades ago, the electronic records have digitized healthcare, and ultimately what happened was we went from a paper process and digitized the paper process, and nothing changed, because the process was exactly the same and they didn't actually change. It was just a digital version of that process, and we missed a huge opportunity. And I personally think that set digital health back decades, and we can't let that same thing happen again with clinical AI. So we have to be very deliberate about how we think, what in 15 years time should this health system look like. Ultimately what it looks like is agents making decisions, and that only happens if you're able to kind of build this kind of integrated future. So that's a very quick overview. I'll stop there. Happy to use the last kind of 5-10 minutes or so for a bit of discussion, but happy to take questions.
Thank you. This is great. Just a quick question on the regulatory compliance side of it. So when the physician is actually using this to guide them in deciding diagnosis, so it's practically classified as an assisting device in different terms. Is this being documented that the physician is actually using this and assisting their diagnosis, or is it just purely the physician's decision, or is it personal? Everyone can do whatever they like.
Yeah, it's a great question, and probably the topic of a 3 or 4 hour conversation there. But it depends on how far into the future you want to look. So let's look 50 years into the future. It's a class 3 medical device. So that is making an autonomous decision for patients. That's where this needs to get to. Healthcare technology needs to have deflationary economics. There's never going to be enough doctors, never enough nurses, never enough pharmacists, regardless of people thinking it's going to take their jobs. We need to get to the point where it's making autonomous decisions. What's the path and how do we get there? So basically it becomes a medical device if it meets 2 criteria, broadly speaking. It takes patient signal, i.e. whether it's a history or whether it's like ECG signal, whatever it may be, and then it can't be independently verified by the clinician and they're not in the loop. So this can be deployed and not meet the medical device criteria. So basically, patient comes in, I've got chest pain, the system queries your knowledge base, brings up and says, hey, it sounds like they're having a STEMI, this is the next best step of what your system should say. Physician can see, oh yes, I can see what PDF that's pulling from, so not a medical device at all. As you move down that spectrum, it can be pulling that information in from the patient, pulling their ECG in, showing that there's ST elevation on the ECG, querying your knowledge base, saying that it's a STEMI, and then automatically ordering the cath lab to be prepped. That's a medical device. And the further you get down that, it becomes class 3.
Okay.
Most of these, so globally, this is handled very differently in every geography. The US is a bit more lenient with regards to what should be and shouldn't be a medical device. Whereas in the UK, especially Europe, this is automatically a medical device. So they want these to be class 1. Some of them want to be class 2A. So it just depends on what geography you're in, and it depends on the intended use case of what it needs to do within the system. Promising, yeah. So I'm optimistic. Yeah. Any other questions or comments? Yes.
I see this is really beneficial for your established patients, but what happens for your transient vanguard patients who drift from system to system? Do you think there's a higher risk for error if you come from a centralized database on those patients, or what does that look like?
Yeah, so I think that's again, the ideal world is we know absolutely everything about the patient. We know absolutely everything from a blood test point of view, and then it's all there in one place. I think regardless, you can only do with what the information that you have in front of you. You can do your best with what you have in front of you, essentially. And that's still better than not having any of this. So, you see a patient that has been to multiple systems, it's the first time this patient has come to yours, they'll still have signs and symptoms. You mightn't have all of the history, but you'll have exactly what's happening at that point, and you'll be able to take that and query your knowledge base and say what the next best step is. As their journey evolves and you learn more of that will feed in, and that might change the treatment trajectory and treatment path, but ultimately you just have to do with what you can. Any other thoughts, questions? Yes.
Like, is this like I have 3 counselors in my behavioral health? These are the drugs I have in my pharmacy. These are the people I have in the ED to follow. I need to have a person admitted this is what's going to happen, or there will be explanation. What information internally are you collecting and using?
Yes, for our own platform in Eolas, or in yeah.
For each class.
Yes. Yes.
What institutional information are you pulling?
Yes, so we pull from it's either one of 2 buckets. So one is the tacit knowledge that exists in people's heads, and we have a feature to crowdsource that. But the other bucket is basically the policies, procedures, guidelines that already exist. So one of the really strong use cases is in antimicrobial stewardship, so treating severe infections, because every health system will have their own guidelines because of antibiotic resistance patterns. So we'll feed all that in. Someone comes in with severe pneumonia because of the resistance in this area, this is the best antibiotic. So that's the type of information. Any other questions? No? Happy enough? Lunchtime. Brilliant. Very good. Thank you very much. Cheers.
Thank you.